All right. Well, good afternoon, everybody, and thanks for joining us for this first lecture in the series of cardiovascular lectures that we are arranging. Thanks to Dr. Al-Sheikh for initiating this. And I'm getting a message that you can't hear me. Can everybody hear? Just verify that, please.
I can hear you great.
You can hear me, okay.
As can the chat.
Okay, all right, let's see. So the topic we have picked is obviously because of this COVID-19 problem we're dealing with. I thought we would at least look at what the data is out there, what we can use, and okay, I've got to find a way to minimize these interruptions. Sorry. So I thought I'd review the data and present some of it, and also discuss some of the arrhythmia that go along with treating patients with COVID-19, and also take this opportunity to discuss issues with long QT interval, since we deal with that almost on a daily basis. So what we know so far is from anecdotes. There's not a lot of published data. Obviously, people are busy taking care of these patients, and I'm sure once this is over, we'll have a lot of data to look at. What we know so far is that there's a fair amount of patients who develop arrhythmias. About 16.7% of these patients in a series developed cardiac arrhythmias. And of those, 7.2 developed acute cardiac injury. And then that's being recognized more and more as myocarditis or a pancarditis type of presentation. So the mortality with in patients with COVID-19 who have pre-existing cardiovascular disease is higher than patients who don't have cardiovascular disease. I think that much is well established. And so the mortality rates are running about 10%. These patients, as you know, develop a cytokine storm. They have certain inflammatory response. It leads to ARDS, also leads to myocarditis. There are cases of acute onset heart failure, myocardial infarction, myocarditis, cardiac arrest. And some of these issues will be discussed with you by the other presentations that are to follow from the non-invasive group and the interventional group. What is the best approach to manage those situations? The cardiac complications so far are on par with those of the previous viral infections that occurred, the SARS and the Middle Eastern respiratory syndrome. So just dealing with patients who have who are critically ill. I mean, this is just a general slide, and you will see that patients, most commonly the arrhythmia we see is sinus tachycardia, obviously, because these patients are under a lot of stress. There's adrenergic drive, there's hypovolemia, work or breathing, all those things that cause sinus tachycardia. Ventricular arrhythmias can occur. These patients can get PVCs, ventricular tachycardias. Also, these are adrenergically driven. And torsade can happen, of course, in patients who are have sepsis and comorbidities. And obviously, in this patient subgroup, we're also dealing with potential drug interactions. So as we'll talk about those, as these patients are receiving certain drugs, they may be at higher risk of developing QT prolongation and torsade. As far as bradyarrhythmias are concerned, they are less common, but most commonly you'll hear from the ICU when the patient is getting suction, they develop either sinus bradycardia or heart block, and that's usually a vagal phenomena. AV block, complete AV block has been reported in one COVID patient, and it wasn't clear whether that was really related to the viral infection or it was just somebody who was older. The patient was older, but they noticed that they had complete heart block. So one patient obviously should not make us think that this is a a specific arrhythmia to this infection. So the etiology of arrhythmia in the ICU, we're dealing with patients who are critically ill. They have electrolyte abnormalities. Hypo and hyperkalemia are most common. Anemia, fever, hypoxia, hypovolemia. Hypovolemia is also interesting because sometimes it leads to, if the patient is inadequately volume depleted, they will get inotropic agents sometimes. And we've seen that where that actually makes the situation worse. Not only does it cause further hypovolemia, but also cause further hypotension, but also causes ventricular arrhythmias. Hypervolemia, just by mechanism of stretch, myocardial stretch, can cause arrhythmias as well. Myocarditis, this could be medication related. Sometimes the patients have dialysis catheters that are too distal, and it's usually not a dialysis catheter. I've seen other catheters that sometimes the midline catheters and all could be in the atrium and touching the wall. It's a rare situation, but does require that I think the X-rays should be reviewed on these patients when you get called for arrhythmia management. Now, once cardiac injury has occurred in a COVID patient, the mortality is quite high. So there's COVID patients who don't have cardiac injury, and then there's patients with cardiac injury. And so once they develop a myocarditis, the mortality may be as high as 50%, 51%. These patients get both ventricular and atrial arrhythmias. And the drugs that are being used for some of these patients cause QT prolongation and torsade. Not only that, there's difficulty in monitoring these patients because of the risk of contamination of the healthcare workers. And that's true for inpatients, obviously. And also there's difficulties in monitoring these outpatients. So if you were to treat somebody with one of these drugs, what precautions do you take to monitor them when they're at home? And finally, the difficulties in resuscitating COVID-19 patients. There are some schools of thought that are saying that if they are very critically ill, maybe they should not be resuscitated. And I hope we never get to the point where we have to change practice in that regard, but that's something where more additional data will be helpful. So what are the issues for healthcare providers? We have to limit exposure to ourselves and the ancillary services. We have to reserve echoes, ECGs for situations that may cause significant management changes only. So you have to be careful, sending the techs in for daily EKGs or echoes that may or may not change your practice. Now there's the option of inpatient mobile cardiac telemetry. So these patients, and we'll talk about that, and that's something creative that is being done in the New York area, where obviously they've had a lot of cases. And there's this other issue of, could we be using a life vest on patients instead of sending a healthcare provider in to shock the patient and do CPR? Is it possible to actually have a life vest on critically ill COVID patients so it can automatically defibrillate them if needed? Now, going through the drugs, as you all know, there is a lot of interest in hydroxychloroquine, Plaquenil. It's been used in several hundreds of million doses worldwide, mostly for malaria. And I have previously not heard, yes, we are concerned about the QT interval, but in large population studies, there hasn't been a lot of people dying suddenly after malaria treatment. So that gives us some hope. The study that is being used to justify it for COVID is small, 26 patient French study. It showed that the time of resolution of the viral shedding was reduced compared to 26 versus 15 patients, so very small study. In itself, if you look at the package insert of hydroxychloroquine, it can cause a fatal cardiomyopathy. It can cause heart block, sinus bradycardia, and it can cause long QT. Now, the long QT issue is not always linear, and that's something to understand, is that you can give the drug to a patient, it may prolong the QT interval, but after the QT has prolonged, the risk of torsade is unclear. It's not always a linear. It doesn't always mean that your risk is lower at 500 millisecond and higher at 550 milliseconds. So that part is unpredictable once the QT does prolong. The incidence of torsade itself is unknown, because again, most of these doses have been given in third world countries, outpatient, and I don't think anybody has done much of monitoring for ECGs, et cetera, after the patients were given chloroquine. And now what about azithromycin? So azithromycin, there's a very large study from Korea, South Korea, where they had almost evaluated 400,000 patients retrospectively. And they found that about 30% of these patients had QT prolongation. The QT prolongation was mild. And more prominent effects were in patients who were older, greater than 60 years of age. And however, the risk of torsade was still very low in those patients. So although it does cause QT prolongation by itself, I think the risk of torsade has been low, use of azithromycin. So now, what are the implications for COVID patients? There is the risk of individual drug therapy is probably low based on what we know so far. The risk of combination drug therapy should be monitored. Yeah. So once you start combining drugs that cause QT prolongation, then we don't know. This is the data that is not out there. We do have this scoring system called a Tisdale risk assessment, which can you excuse me for a second? I'll be right back. Sorry. Okay, I hope everybody can see the slides and hear me now. All right, so we're going to talk about the Tisdale score a little bit later, and I think this will help you stratify patients who have been on QT prolonging drugs, and also adjust the doses of these other drugs when they're added. One thing I would suggest is avoid amiodarone. If possible. Obviously, if the patient is critically ill and they're dying and there's no other option, then use amiodarone. But if possible, use lidocaine for ventricular arrhythmias. Consider using esmolol if you have atrial fib and rapid ventricular rate. All right, so some precautions. Again, this is going to go back to that Tisdale score. So when you have combination therapy with hydrochloroquine and azithromycin, and now you have QT prolongation, I think it's best to look at the score again and really avoid combination therapy in patients where the QT is greater than 500 and they have other risk factors. And this is also true for outpatients as well. So just some basic information, and About QT monitoring. So most of you should know this. The QT interval starts from the onset of the QRS, goes to the end of the T wave. Now, this includes both the ventricular contraction phase, the QRS, as well as the repolarization phase, so which ends at the end of the T wave. So that's the QT interval. And once you get that, you can correct it for the heart rate. Now, there's some suggestion that, if you want to measure the QT interval very accurately, it's maybe best to do this at a 50 millimeter per second paper speed and an amplified electrocardiogram, so you can see that T wave better. And sometimes defining the end of the T wave is not easy because of the way the amplitude might be, and we do see these EKGs where it's very difficult to tell the QT duration and the QT interval, and mostly because the amplitude of the T waves is so low. So in these cases, it is recommended that you draw a tangent. So you take a caliper or on a piece of paper, draw a line at the most obvious slope of the T wave and see where it crosses the isoelectric interval. You measure the QT time to there. And there could be a huge number of variations to this. You could have, I almost never know what to do with that U wave. And I tend to not consider it part of the interval, but be aware that the U waves can also be signs of delayed after depolarizations, and they may be arrhythmogenic. But measuring the QT interval by itself requires drawing a tangent to the isoelectric line, then measuring the QT interval. And this is an example where they considered including that U wave at the end. The one thing I find very helpful is just an eyeball test. And by the eyeball test, I mean, if you look at the EKG and your QT interval is more than half of the RR interval, so it goes past the half of the interval between the two R waves, I consider that abnormal. So I think that's a good place to start. But the other question is, what lead do you look at? You want to look at the lead with the most prominent T wave. Usually that's lead 3 or lead 2, one of the inferior leads. So what are normal intervals for patients with QT, for the QT interval? So males generally tend to have a slightly shorter QT interval. Up to 450 is normal. For females, up to 470 is normal. And as you can see, this comes from population studies. There's quite a bit of distribution of what is normal. As you get towards the last 1%, you could get into a range where you're worried about long QT syndrome. Do these patients who have a QT of 460, 470, are they really just normal? Or what if you did a genetic test and you found an abnormal QT? So there is going to be an overlap in that last part of that curve. So that just tells you the same. Again, adult males are allowed a little up to 450, females up to 470. Now, measuring the QT interval has to be corrected for the heart rate. So there are several formulas available for this. There's this Bazzett's formula, Fredericia and Framingham formula, and there's one or two others. And what they're trying to do is give you a range of the QT corrected to the heart rate. So typically at a faster heart rate, the QT interval tends to shorten. And at a slower heart rate, the QT interval tends to prolong. So you have to correct that so you know if it's normal or abnormal. None of these formulas are 100% accurate. And the Bazzett's formula, which is the most commonly used, overcorrects the QT for faster heart rates and undercorrects it for slower heart rates. It's good to look at a combination of these, and they are available on the automated electrocardiograms. So on the automated, if you measure the QT interval and it correlates with what the computer read, then I think you can trust the corrected intervals also. So here's a typical example of what torsade looks like. So you tend to see these undulating ventricular waves, and typically this is an example of a non-sustained torsade. And then there's example of that sustaining into ventricular fibrillation. As you can see, it becomes finer as time goes on. Okay, so another typical initiation. So there's this is a typical initiation of torsade. We call it a short, long, and short interval preceding the onset of ventricular arrhythmia. So the short interval is caused by a PVC or a PAC, typically a PVC. It creates a pause. The pause then leads to a situation where the QT interval prolongs, and that promotes the onset of this torsade rhythm. So long, short, or short, long, short intervals are arrhythmogenic. And typically you'll see these in patients who have bradycardia. You generally don't see short and long, these sort of changes with tachycardia situations. So just some things to remember. Genetic long QT issues are usually adrenergic dependent, meaning they're triggered by catecholamine stress. So if somebody is excited or they're running or exercising, they tend to be triggered by that. And the long QT1 is triggered by swimming typically, and these are usually on the board questions. Long QT3 happens to be triggered by an alarm clock typically. Drug-induced torsade is usually pause dependent. So looking at the example I showed you earlier, so there's going to be a pause dependent type of arrhythmia generally that goes along with drug-induced torsade. All right, I'm going to go over some of these antiarrhythmic drugs and to try to explain those to you, what some of the precautions are. And the Vaughan Williams classification shows that there's 4 classes of antiarrhythmic drugs. The class 1 are the sodium channel blockers, class 2 are the beta blockers, class 3 are the potassium channel blockers, and class 4 are the calcium channel blockers. All right, so this is generally a slide that puts everybody to sleep, but I think I'm going to try to make some sense of it for you. This is the action potential that is of a ventricular myocardial cell. Now, there's 2 different kinds of action potentials typically in the heart. There's those that are associated with the sinus node and the AV node and the Purkinje fibers, and they are designed for automaticity, so the heart can repeat a contraction at a certain speed or repeat excitability at a certain speed. And then there's action potentials that are designed for the ventricular myocardial cells that also facilitate the contraction of the heart muscle. So this is an example of ventricular myocardial cell. So the electrical membrane potential will generally stay at about minus 96 millivolts on the membrane of the ventricular cell. And there's the potassium, it's a slow inward current, which is keeping it at this phase 4 of this baseline. So that's the baseline characteristic of the membrane, is that the potassium is slowly leaking inward. Now, phase 0 is the sodium channel, where the sodium channels suddenly open up, and there's a lot of sodium channels, so that leads to a very rapid influx of sodium into the cell and causes the potential to increase to a positive 50 very quickly. And so this is the sodium inward channel. Now, the next phase is called phase 1, where there's a transient outward current of the potassium. So remember, the potassium was trying to leak inward into the cell, and that suddenly changes here. These channels are voltage gated, so they open and close based on what the voltage is. So it's kind of like a handoff or passing the baton from one channel to the next. So at this point, the potassium starts going outward, and it is interrupted by the flow of the keep losing the mouse, sorry. By the flow of the calcium inward, which is phase 2. So if the phase 2 was, if this phase 2 was not there, the potassium channel would basically look like this. It would bring the potential down to here. Okay, so you wouldn't have phase 2. Why is phase 2 needed? Phase 2 is where the calcium goes into the cell and allows the myocardium to then contract. So that is why this is different in the ventricular myocardial cell, because it allows that contraction of the myocardial tissue. And then, of course, there's the ongoing potassium channel, the K going out and finally back to the baseline. So during this time, there's a contraction of the cardiac muscle, mostly facilitated by this phase 2 or the calcium influx. All right, now what do the antiarrhythmic drugs do? So the antiarrhythmic drugs work on different parts of the action potential. So there's the class 1A, quinidine, procainamide, and norpace or disopyramide. They tend to work on the sodium channel, which is this, the first, the phase 0. They tend to flatten out the action potential, but note that they also prolong the total duration of the action potential, and this leads to some QT prolongation. The next one is class 1B or lidocaine and mexiletine, and they do flatten that sodium channel again because they are sodium channel blockers. But note that they don't cause the action potential to prolong. So they do not prolong the QT interval. In fact, they shorten it somewhat. So we like to use mexiletine quite a bit and lidocaine in patients who have QT prolongation. The class 1C are propafenone and flecainide, and they tend to be pure sodium channel blockers, and they do cause this slowing of the action potential duration, but they also do not cause, or they cause very little QT prolongation, and that's not typically a side effect of these drugs. Now, this is an action potential of the sinus node. So when I told you that there was a difference in the action potential, see how this one is straight up and down? This is a pacemaker cell that has automaticity compared to the ventricular myocardial cell that has this extra bump because of the phase 2 where the calcium is coming in. So that's a sinus node activation. And but the beta blockers do prolong this phase 4 and slow down the speed of the sinus node activation. So that's how the class 2 drugs work. Now, class 3 drugs are the potassium channel blockers, so sotalol, ticosine, and amiodarone, and they purely prolong the repolarization phase, and they cause this QT prolongation. Class 4 is the calcium channel blockers again, and all they do is again slow the rise of the action potential and hence slow the speed of the heart. So again, you can see that there's no effect of the beta blockers and calcium channel blockers on the ventricular myocardial cells, but they're purely acting on the sinus node and the AV node. So these differences are important to remember. So when you're looking at QT prolonging drugs or drugs that would not prolong QT, remember to use mexiletine and lidocaine. All right, one last discussion on this QT and the action potentials, and then we're done with this. So there's a concept called the transmural dispersion of repolarization. And what this means is that within the myocardial cells, there's a difference in how the activation is between the epicardial cells and the endocardial cells, as well as in between. So there's these cells in between called the M cells. The M cells were named after Dr. Gordon Moe, and who discovered them. And they are cells that are basically referring to his Purkinje fibers, the Purkinje fibers, and they're the ones that are also responsible for some automaticity. In a normal heart, there's not much difference in the action potential duration. So the endocardial cells do take a little bit longer to recover versus the epicardial cells. And as you can see, this might create electrical gradients. So you could see some current flowing from the epi to the endo side. Now, versus if you give an antiarrhythmic drug, now certainly you've made that difference much bigger, especially true for those middle or M cells. The M cells prolong their action potential quite a bit with adding a drug relative to the other cells. So this can create, one, it creates a prolonged QT interval, and secondly, it creates this dispersion of repolarization where there's a big difference in the resting state between the epicardial side and the endocardial side and the mid cells. And so that can lead to currents going both ways and then eventually cause this problem of torsade. So, okay, so I'm just going to leave it at that, and then let's move on to some other examples. So this is basically what the drugs do. They prolong the action potential duration. It leads to, on the surface, it looks like this. The T wave goes out, the QT interval prolongs, and then you set up for the situation of torsade. Now, what are the common drugs? And these, I think many of these are familiar. Sotalol, cisapride, which is no longer on the market, amiodarone, erythromycin, ibutylide, which was in vogue for a while, but it caused almost a 15% risk of torsade. In this slide, it says 25%, but we don't use that much anymore. And then there's some of the other agents. I think if you read through the list, you'll see there's some of them are fairly common. So this is the Tisdale score. And I encourage you to either, you can take a snapshot of this now or find it later in the slides, but it's a good one to carry around for anybody who's treating patients who might be on QT prolonging drugs. So the things that increase the QT interval, and they're given a scoring system here. Now, the scoring system is obviously not exactly weighted. It is, but I think there's some increased weightage given to certain things. So age greater than 68 years, female, being on a loop diuretic, serum potassium of 3.5 or less, and a presenting QT of already prolonged. So now we're looking at getting 2 points for each one of these. Acute myocardial infarction, heart failure with reduced ejection fraction, and then things like if the patient is on 1 or 2 QT prolonging drugs, sepsis, you can get a maximum score of 21. Anything below 7 is low risk. Anything between 7 to 10 is moderate risk, and more than 11 is high risk for torsade or QT prolongation. So I think frequently when we're dosing patients, especially when they come in for something like sotalol initiation, I think it's something to be aware of. And I think I personally tend to use a lower dose of these drugs, especially in people who have heart failure, older women, because they have some of these risk factors already for QT prolongation. Just a few words about some of the antiarrhythmic drugs, because I think many of you will be involved in using these. So flecainide, propafenone are generally can be used as and started as outpatient. You don't have to admit patients to initiate those drugs. Sotalol is usually an inpatient initiation, and there are exceptions to that. Multac can be started as an outpatient, even though it's a class 3 agent. Ticocin is strictly inpatient. In fact, we feel strongly enough about it that if somebody was on Ticocin in the past and they come off of it for whatever reason, when you reinitiate them, you should readmit them. So amiodarone is another drug, and it can be used either inpatient or outpatient. One other thing I'm going to say about drug is flecainide. Flecainide has this mechanism called use dependence. So what that means is as the heart rate is increasing, the cardiac cells are uptaking more and more flecainide, or at a higher rate. And that causes increased toxicity. So the way we test these patients is we put them on a treadmill. If they're on flecainide for, let's say, PVCs or for atrial arrhythmia, it's a good idea to put the patient on a treadmill, increase their heart rate, and see if the QRS widens with exercise. And so for that reason, to avoid that proarrhythmia, we also like to give these patients a beta blocker. So flecainide generally is used with a beta blocker on board. Sotalol has the opposite effect. So it has mechanism of reverse use dependence. So the slower the heart rate is, the more likely the cardiac cells are to uptake sotalol. And so it's always a good idea when somebody's, let's say, an AFib, and you put them on sotalol. Now you cardiovert them, the heart rate is likely to change drastically. So they could go from a heart rate of 110 beats a minute in AFib to a heart rate of 50 beats a minute after cardioversion. And it is very important to look at their QTC when that is done, because now certainly the uptake of sotalol will be higher, and you may see a big change in the QT interval due to the change in heart rate alone. Some of the precautions for these drugs: for renal failure, generally you want to adjust the dose of sotalol or ticozin, or not use them at all, depending on the grade of the renal failure. Patients who have had previous myocardial infarction, you typically don't want to use propafenone or flecainide. And in fact, there may be absolute contraindications in those patients. And low EF patients, I think your options are limited. If the EF is very low, I think you want to either use amiodarone or dofetilide. And sometimes we have used sotalol, but typically amiodarone and dofetilide are the first two choices. Isopril is a very effective drug for drug-induced torsade. As I previously said, that there is pause-dependent QT prolongation in these patients. So you want to use a agent like isopril that increases the heart rate, shortens the QT interval. And we've managed a lot of people with this drug, and it's very effective and definitely saves them the other treatment of getting a temporary pacemaker put in to increase the heart rate. So with all this going on with the COVID crisis, the FDA has expanded the use of vital sign monitors. So they've allowed use of home monitors, all kinds, from thermometers, ECG monitors, cardiac monitors, pulse oximeters, and etc., electronic stethoscopes. So as far as we are concerned, I think it does affect us in these monitors, because if you have a patient with COVID-19 in the hospital who's requiring monitoring, I think we have some options that might help our staff limit their exposure. So there has been some work done already on this with BioTell. BioTell is our provider of the monitors at Baptist. And so they have two systems for monitoring, or the MCARD, or the mobile cardiac outpatient telemetry. There's a lead wire adapter that looks like this. So there's a heart monitor with 3 electrodes. And then they have a patch monitor. These monitors transmit to a cell phone. The cell phone sends a signal to the base unit or to the central monitoring station, which is off campus. And for them, it's, I think, in Chicago. And then they, based on notifications, call the physicians back. So the lead wire adapter versus the patch. The lead wire adapter gives you multiple ECG leads. It does QT monitoring. And the downside is it has to be changed daily. The patch monitor, on the other hand, only does one lead analysis, and it does QT monitoring, and you can put a patch on a patient for 5 days and then not have to worry about it. So the left example is of a daily report of a 3-lead system, and there'll be multiple electrocardiograms, multiple different vectors shown, versus the patch monitor, which has one single ECG, but it is able to get you get your QT interval. So like I said, the way this monitoring is done, it is somewhat creative, but the patients are in the hospital. They get the patch put on. The patch will send a signal via cell phone to the central monitoring station, which is remote. If the notification criteria are met, let's say the patient has prolongation of QT interval and they check that twice a day, or if they have ventricular tachycardia or torsade, then in those cases, they would make a phone call to the hospital telemetry unit, and then the intervention is performed. So at that point, the clinician can go to the patient's room, check on them, and then see if anything else needs to be done. The turnaround time for this is about 3 minutes. So this is, again, a single case. They've already had a patient saved like this, where patient had remote monitoring in the hospital with COVID, and that patient was able to be treated by dose changing, by changing the dose of the chloroquine. As you can see, there's a downside to that because of the turnaround time. So the BioTell QT monitoring has been approved by the FDA. The QT is measured daily. It is posted to the web portal. If it meets certain critical criteria, the physicians are notified immediately. And they do a single lead QT monitoring. If it's AFib or irregular rhythm, then 3 measurements are taken. They use the Bazek's formula, and the heart rate and QTC are measured manually using electronic calipers. So who do we select for inpatient monitoring? Let's say we have a large number of patients with COVID, and we want to try to use the inpatient monitoring. I think the one downside of this is, of course, I'm worried about the turnaround time. Would it be immediate? Would it be as good as somebody who's on a regular telemetry monitor? So in these cases, it may be best to start with patients who have a low Tisdale score or less than 7. So if these patients were very high risk and they had myocarditis or something like that, it may be better to go with a traditional monitoring approach. Now, what about outpatients? Outpatients as well could be monitored if they're receiving hydrochloroquine or azithromycin. And it would all depend on what the resources are available and how many patients we have, et cetera, and what the patient characteristics are. Okay, so that concludes all the slides, and we'll take questions. Thank you.
Thank you so much, Dr. Verma. I only see the one question so far in the chat from Anita Summerlin, the very bottom one. Do you see that? It was why I'm not Torres. I'm probably saying that wrong. I heard you say it specifically and not just VTAC or AFib.
Okay, let me see.
Yeah, the chat, it's the most bottom one. And yes, I
why
can.
torsade specifically and not just VTAC or FIB? I'm not sure I understand the question. I mean, I think you may want to expand on that question, what exactly it means. So the next question is, what would be a good way to predict myocarditis but limiting echocardiogram tech exposure? So I think I'm going to leave that to our echo folks to give you, I don't know if there's a way to predict it. I think echoes are being used very sparingly from what I understand so far. Certainly, serial echoes would be out of the question, I would think, in these patients. I think you want to limit how many echoes you do, and but probably if the patient was very ill, I think getting an echo would be a good idea. But honestly, I don't know enough because we haven't treated these patients ourselves directly yet. So I think Dr. Alchik is trying to clarify, why would you call it TDP versus polymorphic VT? So the difference in polymorphic VT is, so the difference is the additional QT prolongation. So if you have QT prolongation with polymorphic VT, we tend to call it torsade. But you could have polymorphic VT without QT prolongation also. So why does long QT send them into torsade and not just monomorphic VT? So I think for the reasons I explained with that, it may be because of the disorganization of the myocardial activation. So So remember, I showed that slide of the difference in the action potential duration between the mid cells and the epi and endo cells. And I think because of so much, I can't see that kind of patient developing monomorphic VT. I think it would be because of the chaotic electrical signals, they probably get polymorphic VT. So we're getting some input back. The ASC guidelines say to limit the echoes. That's good. And so Dr. Lloyd says that, yes, the EF can drop over a few days. What is the approach to choosing a drug for Torsades, assuming reversible factors have been addressed? So I think this immediate management with increasing the heart rate with drug like isopril or lidocaine, or pacing them, magnesium, typical Torsades treatment. Then, reducing the dose would be critical. In most of these patients, if they're so ill that they need hydrochloroquine and azithromycin, probably means that you still have to continue those drugs to save their life, but reduce the dose and do some other things on top. Okay, I think that that's all the questions I see here. So, well, thank you very much for logging in. Hope you enjoy the rest of your day, and be safe.